Good morning, everyone. I am Robert Hersey, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Crisis Management for High-Risk Populations. This webinar is being made available through a collaboration of the Florida Department of Children and Families and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the chat panel. The button to open the panel is usually located on the upper right-hand side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options are posted in the chat panel too. If you continue to experience poor audio through your computer, try rejoining the webinar and use the I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and the materials used in today's presentation will be available on the FATA website within 30 business days. To access the recording in PowerPoint, go to www.fata.org, navigate to the Resource Center, and then click on Training Library. FATA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FATA website. You will first need to register or sign into your account to complete the evaluation. Information you provide FATA as part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Do note that the evaluation will close at midnight on Saturday, September 9th, 2023. Up to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial CE credit. Our presenter today is Dr. Nicole Klasey. Dr. Nicole Klasey is a clinical psychologist who consults with agencies on trauma-informed care, programming for commercially sexually exploited youth, culturally responsive services, vicarious trauma, and leadership development through Klasey Consulting, LLC. Nicole has been training multidisciplinary audiences on trauma-related topics since 2015. She has taught graduate-level psychology courses on human trafficking and substance use, and authored a commercial sexual exploitation intervention and prevention curriculum. And now I'd like to welcome our presenter, Dr. Klasey. I will turn the presentation over to you.
Well, thank you. And it is a pleasure to be here with you all. It's lovely to see so many of the good mornings coming in the chat. Looks like folks already have some coffee and hopefully have gotten in some self-care, but we will talk about that here in a moment. So in addition to everything Robert shared about kind of me, let me share a little bit more. and kind of our topic today. So, over the years, I've done a lot of work in high levels of care, of inpatient, of residential care with our youth and young adults who've experienced not only a lot of trauma, many of whom have engaged in lots of other risky behaviors, from substance use to self injury to being in abusive relationships to suicidal ideation to homicidal ideation. And the list can probably go on and on and on. And so, today kind of really comes from looking at so many different crises. I've encountered clinicians I've supervised have encountered in doing, in consulting with organizations about really enhancing that trauma informed care at their locations, of how can we really understand and help navigate those crises through a trauma informed lens. So, as we talk today, if there are questions or whatnot, please feel free to ask. Definitely want today to be as helpful for you all as possible. And with that, we are going to dive on in here. So let me read this slide to y'all. This presentation is intended solely for educational purposes. The views, opinions, information, and content expressed in the presentation are those of me and do not necessarily reflect the views, opinions, or policies of the state of Florida, the Florida Department of Children and Families, the Florida Alcohol and Drug Abuse Association, or the Florida Behavioral Health Association. Attendees should note that sessions are recorded and published in various media. All righty. Also, just want to touch here on some of what our objectives are as we go. As we talk, one of the things we're going to start off here in a little bit with is really trying to clarify what a crisis is. And two of those big things that we'll be looking at to really try to understand what's going on so we can make sure we are effectively intervening with our client is really trying to discern, is this client suicidal? We could throw in homicidal for that matter. Or do they have poor emotional regulation? And we'll kind of talk more about that here in a second. Also wanting to identify at least one strategy, one thing we could do to support our clients, our individuals who are in crisis. And lastly, to identify at least one strategy to communicate with individuals during crisis. What might be, one of those things I might need to do in terms of how I'm speaking, how I'm approaching them. Also keeping in mind, and we'll get into this later on as well, that communication isn't just verbal. It's not just the words coming out of my mouth, but my nonverbals, how I'm approaching the individual, what my body posture is, what my facial gestures are, all of that also is a form of communication. I love to start off my trainings and in trainings on this note. So we are going to do that today. Even though we are here for a short time frame, I want us to anchor ourselves in taking care of us. Particularly, as we're going to spend our time today talking about crises. And for folks who have already tried to navigate, or I shouldn't say try, have navigated crises, you know how stressful they could be. Sometimes that stress doesn't hit us till after the crisis has subsided and we realize everything that just happened, and then we can get that flash flood of emotions and thoughts kind of going through us and whatnot. But it becomes so crucial, especially as we think about sometimes folks we're working with, they recognize our push buttons. They know that name to call us. They know that action to do that would get under our skin. And in those moments, it becomes really hard sometimes for us to keep our cool and to stay collected. And one of those things that helps us do that is us intentionally taking care of ourselves. So I recognize we're a large group, so I'm not going to read all the responses out loud because that would probably take us a whole time. But I do want to invite folks to go into the chat box and share, what have you done this morning? Not yesterday or over the weekend or last week. What have you done this morning to take care of you? And this is kind of our opportunity here to share / brag about how we are taking care of us. And as you see some of the thoughts coming in the chat, hopefully it is just an encouragement of seeing how many of us, as we start off our day, are starting off on a good note. And I'm seeing, just going to kind of do a little summary here of seeing a little exercise, some prayer, lots of coffee I'm seeing, and whatnot. And these, again, it just becomes our anchor. And as I have done this work and have worked in, especially in high acuity settings, I have seen wonderful folks in our field lose their cool in the moment because they've neglected taking care of themselves because they were so focused on helping others. And sometimes that ended up in them in some not wonderful situations. There'd be times some wonderful folks got written up, and on some extreme cases, lost their jobs because they weren't able to keep their cool in the moment. And that's just, a reminder for us to make sure we take care of us. All right, so with that, I want us, to start off here and think about, a crisis and how we would define it. So feel free, to go into the chat. I'll read off a few responses that come in. What are some thoughts here as you think about how you would define a crisis? And as we get a couple folks, chiming in here, we're starting off here on this note, and this might kind of sound like a silly note for us to start off on because it should seem apparent, that we understand what a crisis is. But what we recognize is how, say, for example, how I view a crisis might be different than what you do. That might be different than how our organization does. And so it's important that we're clear on what is a crisis, and we're clear on, what are the policies at our organization for how we're navigating crises. So just to share a couple things that are coming in the chat, we got everything from kind of high stress, client or individual not acting like themselves, loss of control, some high anxiety, an urgent problem or situation, even like trauma. It could be unpredictable, overwhelming, client being homeless or living in the car. And even as I'm sharing some of these examples that are coming in, even just pay attention to how broad, and how different some of the responses are. And this again is where it's so important that we're anchoring ourselves in what is a crisis. Somebody having delusions, not eating or sleeping, an escalated situation, somebody struggling with anxiety or depression, someone who's requiring immediate attention, someone potentially facing eviction, who's dysregulated, a medical condition, family matters, low frustration tolerance, not taking meds, all of these become such crucial aspects. And so one of those things, for us and our teams is to make sure we're clear on how are we defining what a crisis is. And that again becomes crucial, because what happens when I start to respond as if it's a crisis situation, but no one else at my organization is, no one else is kind of interacting with this client or even rushing to this client like I am. And that's where it becomes really confusing when we, as kind of the team, when we aren't on the same page. And so also, as we think here about the goal of crisis management, this again is where it's important that we are on the same page and that we're also clear on, kind of what this looks like. So I'll open this up in the chat here. Thank you for everyone kind of chiming in here for some thoughts as to what a crisis is. What are some thoughts here as to what is the goal of crisis management? When we're in the midst of a crisis, we're trying to help the individual. What are some of those goals? Completing a safety plan, stabilization, solution focused and problem solving, keeping everyone safe, reducing stress, safety, listening, increasing self-perception and awareness of coping strategies, engaging in support in support of resources, helping to alleviate some of the symptoms that they're struggling with, stabilization, safety planning, seeing a lot of stabilization and safety, helping client feel safe. I love it. De-escalating the situation, meeting immediate needs. Goal could also be to help client to feel like they're safe. Solution, using CFT, some more safety planning, helping them be able to cope and meet basic needs, building resilience for the next crisis, restoring to pre-crisis functioning. We got more safety and stability, learning healthy ways of coping, maintaining safety, building skills, teaching positive coping, relaxation, learning coping, calming the situation, a little bit more some stabilization and de-escalation, addressing the problem, smoothing the rough places, connecting to community resources, helping them address some of their concerns. Again, stabilization, crises. So, so we're seeing some things here with kind of, we want to focus on safety. We want to focus on stabilization, harm reduction. Love it. And this is where it becomes so important, for us again to be on the same page. Because one of the things I've seen is when our focus, when our goal, our ultimate goal, I would say, for crisis management is some of what is coming in the chat right now, is really looking at safety and stabilization. Depending on what the crisis is, if they're engaging in some high risk behavior, my goal is to ensure safety for them and everyone involved and help them to stabilize. Now, we had some great thoughts, kind of coming in the chat. We have a few more coming in, mindfulness, empathy, linkage to services, minimizing damage. Again, we got some great thoughts coming in. And one of those things that can be confusing sometimes for us is thinking about and discerning crisis management versus their treatment or wellness goals. And, this is where we want to kind of separate them a little bit, because everything that came in the chat are things that we want to help our individuals with. We want to help folks be able to increase their safety. We want to help them be able to increase their coping. We want to help them link, to resources. We want to be able to listen and have empathy and all of those things. But when we're in the midst of a crisis, we got to kind of almost have like blinders on, so to speak, because our focus, what we want that focus to be on, is really on safety and stability. Some of the other stuff we can address once they've calmed down, once we've kind of restored kind of their functioning, where they're functioning at that pre-crisis level, when they're back at their baseline. And when they're back at that baseline, that's when we could do some of this other stuff that's coming in here in the chat. Let's figure out who we need to link them with. Let's figure out, how we could address coping. Maybe in the midst of the crisis, client said a few choice words to me, or called me a few names, or someone else. Maybe they destroyed some property. Maybe what they did really created some ruptures within relationships, whether it was with me, whether it's with family, with significant other, with friends, other providers, etc. And, so once we kind of get them back down to their baseline, then we could address those other issues. But right now, we want to stay focused on safety and stability. And that's so important. I've seen this, especially in higher levels of care, and I'm sure some of you have seen this over the time you've been in the field, when somebody's in the midst of crisis. And then you have kind of the adult saying, "Oh, you can't talk to me like that. You need to stop. We talk like that in here." Or kind of statements such as those. And what does that do to the individual? It only escalates the situation further. That's not to say what the client is calling me, how the client is expressing themselves. I'm not to say I'm on board with that. There will be a time and place for us to address those issues. But in the midst of a crisis, we want to focus again with kind of blinders on safety and stability. We also want to clarify, what is the goal? And, and part of that also helps us figure out what is the crisis, because this is where it makes a world of difference if this client is in kind of an immediate life-threatening situation versus a personal crisis. And for those of us, and we're human too, so we have personal crises. And sometimes, even for us, if we're honest, sometimes in the moment, they can feel like the end of the world, but as we think about it, is it really the end of the world? So I've worked a lot with, a lot of my work has been with our teens and young adults. And whether it be, the outfit I want it to wear to school or to work tomorrow isn't clean. Is that horrible? That could feel like the end of the world for some. Is that a reason for the client, to be calling, freaking out as if their life were in danger? And that's where we want to be able to discern what is going on. And also, eventually, part of kind of that wellness plan too is helping grow that support. So if they were having more personal crises, they had more folks to reach out to besides just us. Whereas if there was more of those immediate crises where life was on the line, they're engaging in stuff that's really hurtful and harmful to them, that those are the situations they reach out to us. Because what I've seen with providers is when clients are calling them over kind of from our perspective can be kind of smaller issues, kind of more of the personal crises, that can really exhaust providers. Because here they are thinking, oh my goodness, clients in this immediate danger, and then they find out they broke a nail. But for them it feels like the end of the world. And so teaching our clients, to even be able to discern and look at who to reach out to is huge. We have in the chat, we use the wraparound process. So we always try to assist them to utilize their natural supports. Absolutely. And even along those lines, one of the things I've seen with folks, and I think if we're honest, this applies to us too. Some folks, some of our individuals we work with, we know they don't have a support system and we got to build it. Others of them do have some supports, in place. But the challenge becomes, do we tap into those supports when we need them? And how many folks in the midst of really needing support, they don't pick up the phone and make that call? And so, one of those things we want to make sure our folks have is having that support system. And then the other thing we want to make sure we're doing is we're addressing whatever problems kind of can come up that play into them tapping into that support system. Because, one of the things I've seen, we'll use substance use, for example. If somebody has been making some strides on their recovery journey, and maybe they have a few missteps along the way, but the feedback they're getting from everyone is, I am so proud of you. You're doing such a great job. Keep up the amazing work, etc. One of those things that can be really hard is to be like, hi, I'm actually struggling over here. And, I might not want to disappoint you. And if you are the only person or people validating me, I might also start to wonder, what are you going to think of me if you knew life wasn't going smooth straight uphill? And so, that's where it becomes so important that we're not only thinking about support systems, but also then getting into what might be some barriers of reaching out to them. What do you need from them? So when you reach out to them, they're able to support you in the ways you need. Because sometimes we make the mistake of thinking, oh, I know how to support them. And we try to be supportive in the ways we know how, but client doesn't experience us as supportive in those moments. Also here in the chat we have, I feel like every session I always stress the supports and resources. Also stress to reach out. And I can even help them to reach out, because sometimes pride and fear or confusion can get in the way. Those become some big barriers. So another thing we want to think about in the midst of a crisis is we want to think about, is this client, do they have poor emotional regulation? Or are they suicidal or homicidal? So when we're working with, a high acuity population, we might have somebody who in the midst of the crisis says, I want to die, or says, I hate you, I'm going to kill you. And when we take some of those statements simply at face value, they're alarming because they're telling us they're going to kill themselves. They're telling us they're going to kill whether it's us or so and so they're going after. Like those are really alarming statements. But this is where we have the job to really discern, is this client an imminent risk to themselves and others, or is this client having poor emotional regulation? And there is no cut and dry, it's when they do this, it's this, and when they do this, it's over here. This is where, we have to have a lot of discernment, and we also have to give ourselves permission to get support from our colleagues and supervisors, because sometimes it's hard to make sense of what's going on. So, one of those things we want to think about, and let me talk about poor emotional regulation in case folks aren't familiar with that term. So when we think about somebody who's having difficulty regulating their emotions, and that's oftentimes where we can see, some of the behavioral outbursts. We could see sometimes just the spewing of emotions and whatnot. It feels overwhelming. And as we think about crises, this is where we want to think about and acknowledge when folks are up here, when they're in the midst of their crisis. They're saying some stuff, and I think if we're honest, when we're in the midst of our crises too, sometimes we might say a thing or two that when we come down, we kind of regret doing. And we see this here with our clients. But the mistake happens when clients up here and they're saying, I want to die or I want to kill you. And we take that statement and we're like, oh, client's suicidal. They need to be hospitalized. And what I have seen, especially from working, in inpatient realms and even residential care, is hearing clients straight out say, I'm here because so and so punished me because I went off. I wasn't suicidal. I said that, but I didn't mean it. And so, that's where we have to discern. So one of those things I like to say, and I've always talked to my clinicians about, is we want to take not only what they're saying up here, but we also want to take into account what are they saying when they're down here. So for example, this is where, and again, I don't have to discern this all on my own. I could go to my colleagues, I could go to my supervisor and say, okay, when so and so, a couple minutes ago, they were in the midst of a crisis and they said X, Y, and Z, or they were threatening X, Y, and Z. I just checked in with them after we've kind of been able to come down, and they're denying any intent. They're denying those thoughts. I want to make sure I'm covering my bases. Help me figure out what to do. And so that's going to be really important because, again, we want to make sure we're not just taking what folks are saying up here, because everyone's going to be hospitalized if that's what we do. Also, let's see here. We have a couple things coming in the chat. What's the best way to help clients regulate their emotions? And also, I've asked if you want to cease breathing or do you want the pain to stop? So let me address these here briefly. So as we think about how to help our folks regulate our emotions, let me just acknowledge I'm going to give a quick little summary. We could do a whole other training just on that topic. But we want to really think about one, what are the emotions they're struggling with? And what are some, I would say, kind of in a kind of catch-all strategy, so to speak, would be breathing. And breathing is something that, one, we have to do anyways to survive, but being able to take those deep breaths in through our nose, holding it for a second and blowing out slowly through our mouths, it literally calms our body. It calms our nervous system pretty quickly, and so one of those things, I would say that's, kind of a great one. That's one I've practiced many times with clients, to help them be able to regulate those emotions in the moment. And we'll kind of get into this a little bit more as we look at different points in crisis, but I'm glad that you're thinking that. I'm glad you're starting to think about, okay, how can we help our client manage and regulate their emotions? And that's also where, kind of this other question that's coming in here in the chat comes into place. As we're hearing clients who make some threats, and I would see this all the time, because I've worked a lot with folks who had a long history of trauma and some mental health issues on top of that, some substance use on top of that. So they had a whole lot going on. And because especially of that early childhood trauma, many of those individuals, whether they were a teenager or adult, hadn't learned to take control of their emotions and manage them. And so they had learned in the heat of the moment, they would say whatever was on the mind. They would threaten whoever it was. And that's where it's important, once we're kind of come down from that crisis, that we are able to discern, is this client a safety risk? Because they were saying some really risky stuff up here. Are they that safety risk? And that's where we could ask, we could do some assessment to see, is this client suicidal? And if not, that's also going to be something that in kind of the more of the treatment and wellness focus, we work with them on. I remember some years ago, I was working with a teen who had a long history of trauma, was constantly getting in incidents and in crises constantly. And we were having a team meeting, and the social worker from child welfare was there. And it was like, this client really needs to stop saying, I'm going to kill myself when they're in the heat of the moment. And, everyone was in agreement. And the social worker was kind of approaching the team of like, why haven't you gotten them to stop it yet? And so it became a beautiful point of some education for that social worker, of helping that social worker understand why the client does that, how that relates to, all that they've been through in life, and how, that's part of what that client is working on. Because, in reality, had that individual not been, in lock placement, had they been in school, had they been, just walking down the street saying some of that stuff, they probably would have been in an inpatient hospital, because those statements were extremely risky. And that also becomes, part of what individuals need to work on. Another thing for us is not only, for us to discern, is this client having poor emotional regulation, or are there some immediate safety risk? We also want to think here about, we have to practice our own regulation skills, because that is going to help us stay calm. And so that's also where it's important for us to think about, what do I do? What helps me regulate my emotions in general, but also what helps me regulate my emotions in the midst of crises. And that again becomes so, so crucial, because if I'm not calm, I'm not going to be able to best serve my client. And one of those big reasons for it, as we are kind of growing in our understanding specifically of trauma, we are seeing that we don't just hold trauma and stress and adversity up here in our minds. We store it in our bodies. And as we're kind of starting to learn more and more about somatic interventions and this mind-body connection, we're really seeing our work as kind of co-regulation. And as some folks within kind of the somatic field talk about, is they talk about my work with the client as it's like my nervous system speaking to theirs. So if I'm not calm, I can't expect them to be calm. And so, I have to regulate myself if I'm helping them, if I'm wanting to help my client regulate. And this is also where, we have to acknowledge we're human. And sometimes we might get lost in the moment, especially if that individual is saying some of those push buttons for me. And this is also where it's crucial we have each other's back. So if I walk down the hall, or if I walk on the unit, whatever setting I'm in, and I see my colleague I see the clients in crisis and I could see that my colleague is starting to get wrapped up in it. I could see that they aren't nice and calm and cool and collected. That is a wonderful opportunity for me to kind of tap myself in and tap them out. And I don't have to go over there being like, you look like you're losing your cool. Why don't you let me help? Because that's not professional. And that's not going to be helpful for our relationship. I could go over there and say, "Hey, you have a phone call in the office. Why don't you let me take over?" And I'm able to kind of excuse my colleague. I'm able to step in, so, I'm able, because I'm calm, to help them. We got a question coming in. What are the specific challenges other than the obvious developmental differences in discerning this with children and adolescents? I would say that's a tough one because, and not just thinking age-wise, but as we think about kind of developmentally, depending on, the circumstances of that kid, I've worked with teenagers, sometimes even young adults who've had quite a history. And sometimes in the midst of those crises, they regress. And that 17-year-old is not acting like a 17-year-old in the midst of that crisis. They might be acting, like a 7-year-old. And so, I think that becomes an important piece too for us to consider as we're thinking about crises is how does what they've gone through, how does that also show up? Because if I'm only seeing their chronological age, and I'm not seeing their developmental age. And again, keeping in mind, when in the midst of that crisis, are they regressing? I'm not going to meet them. And we see this in the chat. Crises look different for everyone, which is also where it's really important that we're having some dialogue with the team. So some things we want to think about here is, does the individual recognize that there's a crisis or there's a situation needing immediate attention? And again, this might sound like a silly one, but there's been times, I've been in the midst of all the adults, all of the professionals recognize this as an immediate situation. This is, extremely concerning, but for the individual, it's kind of like, it's life. I remember some years ago, working with a young man, and he had quite a history, of trauma, lots of stuff going on. And he was gang affiliated, lived in a community of high violence, and he was talking about just the number of times he'd been shot at. Just walking down the street or running down the street once, people saw him because he was gang affiliated and whatnot. And in my mind, I'm hearing red flag after red flag after red flag after red flag of safety concerns. But for him, it was any other day because it was so normalized for him because of what he grew up in. And so just because we recognize there's an issue doesn't mean the client does. Similarly, I could be working with somebody who's using substances, and maybe even has had some overdose. And so in my mind, I'm seeing concern after, oh my goodness, I don't know if you'll be alive next week when I meet you if you continue doing this behavior. But for them, they might not see it. Also, we have here in the chat, I have a client who requested we ask if she had a migraine. And if she says no, that's her way of telling us she's starting to feel a crisis coming on. And that's some great awareness that that client is able to recognize, what are some of my warning signs? And so one of those things too we want to think about here is, where are they at in their crisis cycle? So for example, is this client kind of up here where they're at kind of that climax, so to speak, of their crisis? I'm going to intervene differently if they're up here than if they're just starting to come up from their baseline. And that's going to look different than if my client we've already kind of gone through the climax of it and we're starting to come down. And so that's also where, as we think not only about how crisis is going to look different for each individual, but even for each individual, it's going to, how we intervene is going to be different depending where they are in that crisis cycle. And, and this becomes so important because I've seen, and I'll share a story of here in a moment, when we just respond to crisis and it's like across the board, sometimes those are the ways in which we trigger our clients and escalate another crisis. When I worked in residential, towards the end of that time, the organization had put cameras, in the hallways and whatnot. And so anytime there'd be an incident or a client would make an allegation or have a complaint, us as managers, we would review, film, to make sure, clients were safe and if we needed to do any follow-up with staff or whatnot. So there was one particular staff, and he was a supervisor, and his name was Mel. He was wonderful. He had such a calming presence, and he, worked on the highest acuity unit and did a phenomenal job. One day, he was off at his unit helping navigate a crisis on another unit. And after, I don't even know how much time he was on that other unit. It was a chunk of time and he was exhausted. And right as that crisis was ending, he got word on the radio. One of the girls on his unit was starting crisis, and they needed his assistance. So because that was his understanding, okay, this client's in crisis, and mind you, the client who they were notifying him was on crisis. This was a girl who her crises would last so long. So he was also not only exhausted from just finishing navigating this one, but also kind of dreading how this one was going to go. So you see him in the film kind of come onto the unit almost like guns blazing, like, okay, where's she at, and whatnot, which actually escalated the situation because prior to him stepping on the unit, the staff had been able to helping her come down. But because he came on the unit acting as if she was still up here, guess what happened? She went from coming down to going right back up. And so we watched the film with him, and you could see it on his face. He was like, I had no idea that is how I came on the unit. Like, and he said it with such shame. He's like, as I'm watching this, I see that second incident was my fault because I triggered it. And that's just a reminder for us. We can't just say crisis and we have this blanket response. We have to discern where are they at in that crisis cycle. So some things we want to consider, and this is where kind of some of that communication and all that becomes so important. What does their baseline look like? So and I say this in recognizing, sometimes this might be someone we're meeting with for the first time. So we don't have a lot of knowledge about what their baseline looks like. We don't know any of that. And, and with that, this is where it's important that we are communicating. So if we as a team, we know, okay, this is client's baseline. And even, as somebody shared here in the chat a moment ago, this is also where we could eventually start to kind of help client increase their awareness of this even. So ideally, they start to recognize when they're starting to go up. They start to recognize some of those warning signs. But it's important that we do as well. And so, we also want to identify what are some of those problematic behaviors, whether it is substances, whether it's self-injury, whether it's running away, whether it's engaging in risky sex, whether it is suicidal ideation, self-harm, etc., fighting with others, whatever those behaviors are, we want to identify them. Also, as we think about those triggers, what are some of those triggers? And triggers can be a range of things. Triggers could be internal, so they could be things within me. So, for example, those triggers can be my thoughts, my emotions. So, what happens if maybe when I start to feel angry or I start to feel shame, even though we know for most folks it's hard to even identify shame, that leads to me doing X, Y, and Z. Or maybe it's more cognitive triggers. So when I start to think about X, Y, and Z, maybe if I've had trauma and I start getting flashbacks and I start to think about what's happened to me. Maybe if I am struggling with low self-worth and low self-esteem, and maybe, I got in trouble, maybe not didn't get in trouble at work, but maybe something didn't go well, and or didn't go as well as I thought it would be. And I start kind of in my head, I start telling myself, of course it didn't go well. You don't know what you're talking about. You're an idiot. And I just start saying all these mean and hurtful things to me. And that then leads to me going off. Maybe those triggers are sensations in our body. Going back to something I mentioned earlier, as we think about how we hold trauma and stress and adversity in our bodies. So sometimes it might be a body sensation that then leads to a client going off. Those triggers can also be external, so they could be outside of me. So those triggers can be maybe something that somebody does. Maybe, if we have somebody who's had trauma, when somebody approaches them in a certain way. If somebody is trying to not use substances and somebody's kind of coming right up, and shoving it in their face, you want some, why don't you drink this, blah, blah, blah. That could be really hard. So not only kind of in the environment, but also are there some things, other people may say or do. And, we also want to think about, and again, this is also important that we help increase their awareness of with these things as well. What are their individual warning signs? So what does it look like when I get triggered? What does it look like as I start to go from here to here? And that's important because oftentimes, and I'm sure some of you have heard this with folks you worked with, I would hear this all the time. And I would hear from clients, I go from kind of like 0 to 100 in no time. There's no in between from my baseline to me going off. And although that's what they thought, as we started to break down, what are some of those triggers? What are some of those warning signs? We would see from their crisis to their baseline, there was a whole lot of stuff happening. And each one of those things, each one of those triggers, each one of those warning signs we're seeing becomes an opportunity for us, if we're there with them, as well as becomes an opportunity for them to practice the regulation skills, to practice the coping skills, to reach out to their support system to try to prevent them from taking kind of a step up. And some common warning signs. This could be everything from maybe I start to isolate. So say, for example, I'm pretty social, hanging out with family, talking with friends and whatnot. But as some of these triggers start to come, I don't want to do anything. I go and I lock myself in my bedroom and I shut myself off. I stop responding to text messages, to phone calls, and I just shut down. Maybe, and sometimes those warning signs can be more obvious to those around us. So maybe I just start to get really moody. I'm really irritable. The smallest thing, I like bite whoever's head off, who's saying anything to me. Maybe it's somebody who starts to get a little bit more anxious, where, we're seeing them fidget a little bit more. There's more restlessness, whatever it might be. Maybe it's a client who, let's say, for example, has struggled with suicidality. And maybe some of those warning signs might be starting to listen to really sad, more emo music, staying in the bed, not getting, really struggling to get out of bed and get going for the morning. And we also want to think about here, what coping skills does the individual, what coping skills do they use? And so this is also can be a tough one here because sometimes the coping skills our clients use might not be the most adaptive ones. And that's where it could be really hard. What happens if my client's way of coping is substances? I might not agree with that. But if this has been their main way of coping, I have to acknowledge that's their main way of coping. And the reality here, when we think about coping, and especially when we think more about not using the most adaptive ways to cope, the reality is I'm going to continue to use these unhealthy coping skills until I've learned healthier ones. And not just I've learned healthier ones, I've seen that they work. And while you're working with me on seeing that these ones work, guess what? I'm still using these. So when we expect the fact that we just did a workshop on coping skills and clients should be using those instead of all these over here, we have unrealistic expectations. It would be lovely if that were life. I have never seen that. And I've never, from colleagues and whatnot, I have never heard them say that. That's what happens with their clients either. They have to see, they have to experience this coping skill helps to get that buy-in to start to use this rather than using what's over here. So we want to have an honest conversation, absent of judgment. What coping skills do they use? Because if I really want to be supportive with them, I don't just want to hear what they think I need to hear. I want to hear the honest truth. So what do they do to cope? And again, I might have to check myself so that I don't come across as being judgmental, or maybe I don't say anything, but I have a couple looks, where I kind of look at them sideways because of what they're saying. This is where we also have to remind ourselves, our clients, our individuals are doing the best they can with the resources they have. We have to build on that. And earlier we talked about a support system. So thinking here about who do they have for a support system? And there's lots of things, to break this one down here when it comes to a support system. One, do they have a support system? Secondly, do they have a support system that is not engaging in those risky behaviors? So for example, if we have a client who all their crises are related to substance use and them getting into some pretty serious binds because of the substance use. Well, how is that when everyone they hang out with, everyone they would have for support are also using substances all the time? Not only that, they likely are not going to be so supportive of client not using. And so that, becomes a tough one for many of our clients when not only that, but, I've seen it and it's so heartbreaking, to hear clients talk about the only support they have is us. And that's not to discount how wonderful we are, but to acknowledge the fact that that is sad. It is sad when folks we work with only have us, especially the fact that, we are not always available. There's going to be times we're meeting with someone else, we're in a meeting, we're on vacation, so we can't be available. I'm not available 24/7, and not only that, I'm not in their life long term. I have a short time period with them. And so, sometimes I think we could forget that, yes, it's wonderful that they have us, but for our clients, it isn't so wonderful because at the end of the day, they realize absent of us, they don't have anyone. So we also have to be thinking more on that treatment wellness side. How can we build that support? And in addition, one more thing I'll say about that is also recognizing we're at a time, in kind of the world and right now where so many of our teens and so many of our young adults report loneliness. We have more individuals today, despite being connected on social media and all that stuff. We have so many more individuals today report being lonely and not having a friend. And so we have to think about, how do we build, kind of on the one side, how do we build that support system so that when they need it over here because there's a crisis, or, they're trying to prevent it from becoming a crisis, they have somebody to reach out to. Also, we want to think here about, that focus on safety and stability. And so as we think about that, this again becomes our focus. And again, we got blinders on. So when we're in the midst of crises, our focus is solely on safety and stability. We aren't talking about, oh, do you know the consequences you're going to get for breaking that? Or you are going to be grounded because you just did X, Y, and Z. We are going to save that stuff for later. We're going to save, you can't talk to me like that. We're going to save all of that for later. Because if we're trying to have those discussions now, it only escalates the situation. I have seen this from working in residential and inpatient, that when and sometimes, mind you, I don't think sometimes we even realize we're starting to have those conversations, but something gets triggered in us and we just start like, you're not going to call me that word. And when we do that, it only escalates the situation. And, and this is where it becomes so important that, again, we got those blinders on. We also want to think here about, what type of crisis is it? So not only, okay, we're in a crisis, but we as a team want to be clear on what is it we're dealing with. So, is this client suicidal? And again, we are discerning, is this client truly suicidal, or are they having difficulty regulating their emotions and they're making some threats even though they don't want to hurt themselves? Also, as we think about in a similar way, are they homicidal? Is this client having some homicidal ideation where they're saying, I want to kill so and so, or I want to hurt, so and so, whoever it might be. We also want to think about, are we dealing with self-injury or self-harm? This is where we see that phrase of non-suicidal self-injury. And this is where we start to recognize there is a difference between self-harm, and particularly cutting, and suicidal ideation. And mind you, we could spend, some hours just talking about that. So we're just going to kind of summarize it here for a moment. This is where it can be really confusing to discern, and this is where us getting support from our colleagues and supervisors is so crucial, because I could cut myself, and I could cut myself too deeply, and it was not a suicide attempt, but I could still end up in the emergency room. On the flip side, I've worked with folks who, let's say, for example, get a paper clip, superficially cut themselves, don't even break the skin, but they do it and they say that was them trying to kill themselves. Now that's really confusing sometimes to figure out, what's going on, and, how do we support them with this? Because on one hand, we have a kid or an adult who's telling us, I wasn't trying to kill myself, but passed out because they cut too deeply. On the other hand, we have somebody who's superficially cutting themselves and saying they tried to do that to kill themselves. And so that's where, one, we don't want to assume because the client is cutting, they are suicidal. We as a system have made that mistake too many times. And what I hear in the aftermath is clients saying, I wasn't suicidal. I was being honest with so-and-so and letting them know I cut. They freaked out, and now I'm hospitalized. I'm never going to tell anybody I'm struggling again. And you hear that and you can't help but think, like, I get it. Like, I wouldn't want to tell anybody anything either if that provider overreacts when you're straight out saying I wasn't suicidal. And sometimes when we overreact, that goes back to something we talked about earlier. We aren't regulating ourselves. That's one of the issues. And the second issue is we aren't getting support from others. I feel that pressure on me. I'm making that determination by myself. I'm not consulting with colleagues. I'm not consulting with my supervisor. So again, we don't have to have it all figured out. I've been seeing folks for a number of years. I still consult. One of the things I have drilled into my clinicians that I supervise right now is I would rather you step out of your session if need be to make sure we are covering all our bases and we are able to support the client through this crisis than you feel like you have to do it all by yourself. Finish session, client goes home, and then you come and now we realize there were all these questions that weren't asked, and now there's questions about, is client safe? It is okay for us to get help. We also want to see, is this substance related? And even if it is substance related, what are they working on here? Is this a client who we're seeing some substances, and those are kind of some of our concerns, and their goal is abstinence? Now, if we're honest, we also have many folks. I've worked with many, and I know you all have as well, who are straight out telling us, I don't want to stop. They see the benefits of using. They're seeing it's helping. It's their way of coping, etc. And they're telling us, I don't want to stop. And that, I think, goes back to something someone said earlier, where we have to think about harm reduction. And I say that in recognizing I know not everyone's on board with it. And it can be controversial, but it's something we need to consider. And that, again, I feel like there's many things that could be a whole other discussion. Is it domestic violence? Is this our concern? And mind you, domestic violence doesn't only happen with adults. We see minors. Unfortunately, teen dating violence is extremely prevalent. I have worked with, especially from doing a lot of work around our minors who have been system involved. I have worked with minors who, by the time they're in junior high, have already been in a number of abusive relationships. And we're talking junior high. One of my colleagues she's a lived experience expert, and she has, quite a history of trauma. And what was so interesting was listening to her as her daughter has grown, and hearing her talk about, man, when I was this age that her daughter is, my daughter had already been through, or I had already been through this and this and this and this type of abuse. And her just seeing, like, it's just crazy to me to see that hasn't happened to my daughter. And so we see it here. And even as we think about domestic violence, there again, kind of what I was in a similar way to what I was talking about with substance use. Just because somebody is using substances doesn't mean they are on board to stop. And in a similar way, just because I'm in an abusive relationship doesn't mean I'm ready to leave it, which can be confusing and frustrating and all of that for us as providers when we care and when we worry about the folks we're working with. And so for that client, maybe that goal for them and what they want is to leave the relationship. Maybe where they're at in terms of where they're at in their stages of change is they aren't ready to leave yet. They don't see anything wrong with the relationship. We also have, in the chat, even going back here to substance use, sometimes we could also see some psychosis related to it. Absolutely. I've worked with folks using substances and and they've had substance-induced psychosis. So we absolutely could see that. Sometimes we even have folks, who are in the midst of crisis as a result of their psychosis. Also in the chat, we have a saying is every therapist needs a therapist. Absolutely. One of the things I appreciate about my graduate program was the fact that us getting therapy, it was mandatory. It was like, if you are going to see clients, you need to go see someone. And I greatly appreciate that. And over the years, as I supervise clinicians, that has been something I've talked to them about. Like, if your program didn't, I really want to encourage you too, so you see what it's like sitting on this side. Another type of crisis that we could see is sexual assault. Unfortunately, we see that. And I also want to highlight here that with sexual assault, we hear it oftentimes talked about with girls and women, and we know it happens to them. But they are not the only group it happens to. And because of some of the shame and stigma that could go along with others, in helping, it can be hard to reach out. Even just to share, some years ago, I was working with a man in his 20s. He was a college student, and he was a big guy. He was, muscularly, he was built, he was tall, he was probably about 6'5". Like he was tall, he was big, and he recognized that. And he talked about how this should not, and he was assaulted, and he said, this should not have happened to me. Look at me. When I go out, all of my friends who are girls, they hang out with me because they know nothing is going to happen to them when they're near me. How did this happen to me? And so, there can be, again, a variety of crises. We have a question here in the chat. How prevalent is misdiagnosis of mental health in relation to substance-induced psychosis? So one, I would say, depending on the populations that we work with, but especially where I have seen a lot of misdiagnoses has been in understanding trauma. I actually do another training specifically looking at the misdiagnosis of trauma, because we see how it can show up with everything from bipolar disorder to schizophrenia, ADHD, conduct disorder, so many things. We can miss the trauma that's there, and in alignment with that, many times, we can have difficulty, really understanding some of those diagnoses. And I would say, what I've seen is that is where us who are in that position, to put down a diagnosis, sometimes we need to get a little bit more support with that. And that is okay if we do, because as I meet with the client, I need to discern what those symptoms are that I'm seeing, and I need to be able to justify why I'm diagnosing my client with this and not with this. And I can't just take the laundry list of diagnoses my client came in with. And so, that becomes, such a big one. And want to just open it up here as well. Are there, what are some of the other types of crises you all are seeing with clients, in addition to kind of the ones we've just been talking about here? Any other types of crises you all are just seeing? Incarceration. Absolutely. Death of a family member. So kind of loss, and that also becomes a big one as we think about, grief and loss. It has amazed me, particularly as I've done work with our system-involved youth and families, how many of them have lost individuals. Sometimes it's just a laundry list, and it's like, you are so young. Like, how could you have lost so many people already? And Liz, I see your question. I'm going to type in here my website, so you could get some information there for some of the stuff that I do. Let's see, social media, absolutely. And even social media also makes me think of bullying, and bullying doesn't just happen with our minors. We also see that with our adults. Chronic illness, cultural sensitivity when assessing crisis. And I would add on, not only when assessing crisis, when we are doing everything, when I'm understanding, that cultural sensitivity comes in terms of when I'm understanding who my client is, how I'm making sense of what's going on with them, as I'm creating my goals for wellness, as I'm understanding what does wellness mean for them, what does that healing journey look like for them, and I'm making sure I'm not just imposing kind of my ideals or my cultural values onto them. Also, as we have here with our juvenile clients, adverse reactions to parents disciplining them, resulting in assault sometimes. Dependency cases, absolutely. As we think about some of those crises of kid being removed from home and placed into the system, and that, just being an adjustment to say the least. Terminal illness. We also have here too many registered interns and others don't receive proper and legal clinical supervision from true licensed supervisors, especially in many larger agencies. They are put on the conveyor belt of a client after client all day, one after another. It's terrible for them, the clients, and the profession. We also have homelessness. That becomes such a big one. And also as we think about just the growing, homeless crisis, across the US and predominantly in some of our larger cities. We got child removal. Again, natural disasters, yes, because it seems like just turn on the news and you see one natural disaster after the other, basic needs not being met, economic challenges, and I would throw on there as well, poverty. And one of the things I've seen has been, as I've done work with our system involved youth over the years, and over the past couple years have done some training on poverty. It has amazed me how many folks in our field have come from histories of poverty, and hearing them share how traumatic it was, but also seen when we have been fortunate to not grow up in poverty, how sometimes it's hard for us to recognize some of the privileges that we carry with not having those challenges. And what we see from our families who are living in poverty or facing it, it is terrifying. It is traumatic, to say the least. Immigration, PTSD triggers can lead to crisis. Absolutely. And sometimes, that's too where our clients can really struggle, because as we think about triggers too, they're annoying, to say the least. But part of them being annoying is sometimes they occur right after the trauma. Sometimes they wait a chunk of time, so it might be some time after the trauma when they start to show up. Even when we start to see sometimes where it becomes really confusing is when those triggers show up and I'm in a really healthy relationship. And I would hear this oftentimes, like, I'm in the healthiest relationship of my life, and now this stuff is happening. Like, this doesn't make sense to me. Also, we have here gender identity is huge today. Wanting to use THC without getting the medical card, knowing they'll be tested, the test being positive, loss of work, gender dysphoria confusion. All of these, again, there are many crises our clients are encountering. And this again goes to, it can be overwhelming. And that's where I want to take us back to where we started the day, of us intentionally taking care of us is so crucial, especially as someone highlighted how unfortunate it is, but how true it is. In many organizations, we have high caseloads, and there's lots of paperwork. There's high stress. Sometimes, if we're honest, our colleagues are more stressful than our clients, so there's lots that we're dealing with. There's lots that we're navigating. And that is where it's so important we're intentionally taking care of us. Otherwise, as we're seeing a client who, some of our clients, if we're honest, they're not just experiencing one of these things. They got multiple issues. They got multiple crises going on. It can be overwhelming, especially then. I just kind of, it could feel like I'm just putting out this fire, and in a few minutes, I got to go meet with someone else. We have to take care of ourselves. All right, we are going to look here at a video here that's going to highlight communication during crises. And it's really just a reminder for us as we think about how we speak, what we're saying, those nonverbals. And, we'll kind of talk a little bit more with it after watching it. So enjoy.
Hi there. This brief video is going to describe simple calming and de-escalation strategies. When people are escalated, it often comes from a sense of threat or fear, Even if the threat is not real at the time, their past experiences with people in the world may have wired their brains to expect harm or danger. When we as humans perceive threat or are otherwise incredibly stressed or angry or scared, we activate our survival brain. This more primitive part of our brain has only one job: to keep us safe. It doesn't care about reason or logic. In fact, the thinking parts of our brain turn off and we act mostly on instincts. These instincts include reading nonverbal cues from our environment. Those nonverbal cues are actually more important than verbal cues or what people say to us. So when people are escalated, at their core, they want control. We give them control over their own safety and decisions. Do not block people, corner them, or block entrances or possible escape routes. As soon as you do, they want to fight or flee even more. Give 2 arms length distance. Keep our body posture open so it does not appear that you are hiding anything. Keep your body posture as relaxed as you can, even if it's hard. A looming, towering figure only sends the message that you want to dominate. So if it feels okay to do so, ask them what would make them feel safe or feel better. Put the control back on their turf. Ask what would help. Ask what could happen next. One of the most famous practices and sayings for de-escalation is low and slow, from Teresa Bolick. Low and slow refers to both your body movements and your voice or speech. Just like it sounds, we want to keep the tone of our voice low and the speed of our voice slow. When you lower your tone and speed, it makes it more possible for the other person to process what you are saying and not feel threatened, as opposed to a higher pitched tone and quick speech, which frankly increases stress. Then we also try to lower and slow down our body movements and posture. So try to sit in a chair or on the floor, especially if you're with children, and especially if the person who is escalated is lower down than you. Maybe they're on the floor or in a chair. If you get on an even playing field, this gives the nonverbal cue that you mean no threat. And try to slow down your body movements so as to not further alarm their cues for danger. Move slowly, walk slowly, keep your hands out and open where they can see them. Next, use the tip, name it to tame it, made popular by Dan Siegel. By naming emotions, we gain control over them. Therapists have known this forever. Acknowledge that they may be feeling anxious, angry, especially if it's a child. Stay with that feeling, validate it. Let them know the feeling is okay as long as they stay safe. We also like to say, regulate over educate. When people are in distress, it's not the time to teach or educate or think back about what they could have done differently. The only goal is to regulate their emotions. Usually this is done by giving space and time, staying calm, and helping provide a calming atmosphere. It takes the body 20 to 30 minutes to come back down to baseline after a perceived or an actual threat. Just think of your own situations when something really scared you or startled you. Even if you look like you're getting back to normal, your body is still pumping all those stress hormones for a while. So wait it out. Just help people regulate. If the person was aggressive or destructive, especially if it's a child, there does, of course, need to be a consequence. But wait on talking about the consequence. Finally, two of the most important things you can do all along the way, and best before people get too distressed, or even while they're distressed, is to validate their feelings and be empathic. I see you are struggling. I see this is hard. If it's okay, I'll stay here with you until you feel better.
I love that video because I think it is some reminders that kind of we know or we've heard, we've heard along the way, but sometimes we just need some of those reminders. And this again is where we sometimes forget that even when I have the best of intentions, that I can be one who triggers. I see some requests coming in for the video, and yes, I will share the link for that here at some point in time. When I have a second to grab it, I will include that in. Yep, perfect. Thank you. So we will get that in there. It is in the chat. So feel free to grab it if you'd like it. And, again, it's just those reminders of this is where it is so important for us to see how we come into play. And one of those things I want us to think about here too, especially as we think about factors that we play in. And that also is where, it just becomes an important one that we recognize we're human. And we recognize that when a client is in crisis, yes, it is them, and they are the ones doing or saying whatever it is. But I also have to understand how influential I am. And there might be things I can do or say that ideally are going to help them calm and regulate. But I also have to acknowledge there are things that I could do or say that could actually help escalate the situation. Before we get into kind of this piece here, one of the things I wanted to share that reminded me as I was listening to that video was I want to kind of go back to a lot of adversity and trauma our clients and even their parents, because sometimes if we're working with a minor, sometimes it's the parents who can be a little more challenging to work with. And that is as we have to really keep in mind that trauma and adversity they've experienced as we think about that trauma stress response and how that shows up, because that trauma stress response shows up not only in the face of trauma, it shows up then, but it also shows up when I perceive a threat. So I could be in a situation, and I know I've seen this many times with folks, and I'm sure some of you have as well. We're all, kind of fine, it's normal. None of us are kind of responding, and client responds as if it is the end of the world because something is getting triggered in them and it's kind of stirring stuff up in them. And then we're seeing, whatever behavior comes about as a result of it. So just keeping that in mind too, as we understand crises, that for some of our clients, given the lives that they lived and what they have experienced, it is not only when they are in an actual situation where there's danger, but also in those situations where they perceive it. So getting back to us here. So, and again, just thinking about how we speak, how our nonverbals, all of those play into how we could help manage a crisis situation. And one of those things that is really important, and I know I found really helpful, is being able to figure out what can I tell myself in the heat of the moment to help me stay calm. Because I'm human, and there are things a client can do, or a client could say, or a client can call me that would get under my skin. And as you hear me say that, I challenge you to think about, do you know the answer to what those are for you? What is that thing a client would do? What is that name that if you were to be called it, you would have a hard time holding your tongue? Or if a client were to say that to you. We all have triggers. We all have push buttons to say, and I like to say, if we say we don't, we're not human. We have push buttons. We have to know what they are, because when I recognize what they are, then I could do this here. And so I want us to think about, what do I tell myself? If you already have that statement, or if you don't, what could you tell yourself in the heat of the moment to stay calm? And as we're thinking about this, we're not talking about a long paragraph. We're talking about a short, simple phrase or statement I could say in my head to help me regulate. So I want to invite folks to go into the chat and share, what is that statement you tell yourself to help you stay calm? And if you are someone who's like, I don't know that statement about me, as I share some of these, and I'll share, what I tell myself as well, feel free to borrow some of them. So for me, sometimes I would just tell myself, just breathe, and just as a reminder to calm my body. And, I would tell myself some of what I'm seeing here in the chat. These feelings are temporary. Be responsible, able to respond. It's not about me. Quit taking it personal. This too shall pass. This is not about me. This is only a moment in time. This too shall pass. We've got this. We can figure it out. It's not personal. Just breathe. Mow Larry the cheese. Take a deep breath and say, this shall pass. This too shall pass. This behavior is not about me. Don't take it personal. Breathe. Breathe. It's only temporary. It's not personable. Will I be mad about this in 10 years? Does it really matter? I'm not in danger. Breathe. Don't take it personal. They don't know me. Walk it off. It's okay. God is around me and in me. It's not about me. This is not about me. Everything will be fine. Stay calm. They will calm. Normalize. The patient needs help. You know, you are not doing your job. I tell myself, they do not under my job take it personal. Grace. Inhale peace, exhale worry. What can you control? Not today. It's not about me. Really. You know, I love grace, empathy, and empathy. It's not that serious. Through love and kindness have I drawn thee. Deep breathing, remembering it's not personal. You know, for me, it's been something much more personal. Moving from another country, I always remind myself of my immigration status I could lose if I allow negative reactions. Don't lose respect for the client because they are there, or you're there to help, not an argument. Sense of humor helps. Remembering why you're there. It's not about me. I also recite certain parts of the Serenity Prayer as it relates to the moment, reminding myself God's in charge. Now that I've had self-control myself, it's been a lot about the actions of others being out of control. Relax, relax. I'm here to help. Some wonderful statements. Thank you all for sharing. You know, and this again are those statements where we say to ourselves to remind ourselves, I need to stay calm. I need to regulate because, as I mentioned earlier, when we understand this kind of more somatically, my nervous system is speaking to their nervous system. If I'm not calm and regulated, there is no way I could expect them to be. It kind of reminds me, we see this, it reminds me of my nephew, but I've seen this with clients too. One day, my nephew who's on the spectrum, my sister had gotten after him about something. I don't remember what it was. And they were starting to get into a little argument about it. And my nephew ended up running to my grandma, or my mom, his grandma, and telling on my sister. And he said, you know, mom's yelling at me to be calm, but she's not calm. And this is exactly that. You know, my sister couldn't help my nephew calm because she was getting escalated because of what was going on between the two of them. And my nephew, as smart as he was, he understood that. Like, how are you going to tell me to calm down and you're not calm? And we see that with clients and their parents, you know, all the time. Also, to go through the coping mechanisms, reminding yourself of what you have and what you can do. Having a Snickers even, you know, love it. All right, so now we're going to get into after a crisis, you know, and think about debriefing a crisis. So what are some thoughts here? Why do we debrief a crisis? And so feel free to chime in. What are some thoughts as to why we debrief a crisis? Because when we don't understand that why, how I've seen us view it is this is just another piece of paper when I already got all this other paperwork to do and there's no point to it. And it just seems like it's just some wasted thing that management is telling us we have to do, and I don't really see a point. All right, so we got some things coming in, mostly to explore what happened, how the client responded, and what they could do differently. Cohesion, explore the trigger, prevent further harm, to learn from it, to learn and to better or do differently next time. Gaining insight, learning from the crisis, insight again. Realization of what happened and prevention for the future. Now calm, we can look back and learn from it. Mindfulness, acknowledging the emotion and understanding the trigger. Identify what went well and what needs improvement. We may debrief to understand and break down to have knowledge of when we're calmer and not in the heat, to provide support, to become more self-aware, to maintain safety and security, to show empathy, to learn and grow, unpack the experience and engage in reflection for learning and informing the future, to learn and grow from the experience, to deflect and documentation for funding, to make sure we've handled it to the best of our ability because we experience life afterwards and understand it backwards. Helping the client to learn what triggered them and understand how they can prevent it in the future, learning from it. How myself, the provider, feels about the situation and feel mentally ready to continue working with the client, lowering the internal temperature, helping deal with similar situations, to guide client during an event and learning from it, being in the moment, learning and exploring, processing our feelings. I love that we're also including us here. If it's not debriefed, there's no resolution. It helps us identify triggers and possible coping. I love what's coming in the chat. And one of the things I appreciate that we're seeing in some of your responses is it's not just about the client. It's not just about the individual. It is also about us too. And that becomes a huge one because if we think about it, if I'm truly there to support the client, and especially if we've already done some planning in terms of crisis management, so I'm part of the plan. I've helped create the plan, etc. There might be things I have done trying to be helpful that the client didn't experience as being supportive. Also, earlier when we were talking about crises, we identified that there might be, needs or resources that the client is in desperate need of. How am I supposed to know a need exists until I know it exists? So maybe there was things I didn't even know client needed access to or resources for until now. So it's not just pointing the finger at the client or each other, because sometimes I've seen us do that too. But I want us to think about it a little bit more kind of detached and think about it more. So how can we look at the plan, especially if we have a plan? How can we look at the plan and look at what went well, what didn't go well? And it's important that we also identify what went well. Maybe clients still escalated and we have whatever behavior, it might be. But maybe before the crisis kind of got up here, client did practice some of those regulation skills we've been working on. And that's a huge win because the goal for next time is they practice them a little bit longer. And next time, a little bit longer. So those are baby steps along the way. We also want to make sure we're debriefing the crisis when all parties are calm. And this is easier said than done. Some years ago, when I was working in residential care, there was an incident going on one of the units. And one of the women who was a staff member, she was wearing leggings. And the client, I don't believe it was intentional, but, as she was just kind of grabbing and whatnot in the midst of her crisis, she ended up pulling down the staff member's leggings and underwear. So her, from waist down was completely naked. And here she is on a unit with kids, with other staff members, and she was mortified to say the least. And, it was a lot of work for her supervisors, of being able to work with her to be able to sit down with the client and debrief what happened. And this is where we have to recognize that there are going to be times where I need a moment. Maybe a client hit something in me that really, really stung. That client probably didn't know how hurtful that statement was, but it stung deeply. In those moments, I'm going to need an extra second. But the challenge becomes, I can't let that turn into avoidance. I'm going to have to sit back down and meet with the client. And I need to do it not only when I'm calm, but also when the client is calm. Because if one of us is escalated, there's not going to be any point. And so we want to be able to sit down and talk about what happened. So we could address what happened. We could talk about, kind of what happened, what led to it. We could identify the triggers and warning signs, whether we've had these discussions before and we're seeing similar things, whether this is the first time clients in crisis. And we're identifying these. We might be providing some psychoeducation about why this is important, because every time we identify a trigger or a warning sign, there are opportunities to talk about coping and regulation. And that becomes huge. So as we're helping them kind of, see what happened from here to here, each time we could talk about it. And if it's a client we've worked with already, we could also talk about, okay, when we got here, what was going on with you? Were there any coping skills you tried? And we also want to ask that question absent of judgment, because if they didn't try anything, we want to help understand why. And if they start to get the sense from us that I'm judging them for not practicing any, we're probably not having that conversation very long. And then we want to kind of update the plan. What is the game plan going forward? And thinking about that plan twofold. What is client going to do? And client should really, especially as we start thinking about what is the game plan going forward, this is where we should hear client having the active voice. We should be hearing more from them than us speaking, because it is their life at the end of the day. They have to have buy-in. But we're also that second part. How can we support them in the same way, in a different way, whatever that might be? Because the more we debrief crises, and yes, it's taking a little extra time, it helps us understand the why. What led to this crisis? So we could try to prevent it going forward. And this is also where it's really important for us to have conversation and dialogue with each other on the team, so we all are aware of what is going on. All right, so we're going to spend a little time here talking about some safety assessments. So thinking about given our client in crisis, and especially when we start to see some particularly worrisome behaviors, of thinking about what are some things for us to consider. So starting off here with homicidal ideation, or somebody making threats to hurt others. Some things we want to think about here. Is there an identifiable victim? So there's, a difference between me saying, I am going to kill so-and-so, versus me saying, I just want to beat up whoever I see next. Those are different statements. And we also want to think about, what is the threat? And not only, what is the threat in terms of, is it kind of vague? Are they specifically saying, like, I plan to go get a gun and I plan to shoot so-and-so? That's pretty direct. We know exactly what they have. Once we do hear what the threat is, do they have access to it? And this too is especially when we start to get into some more serious issues like this. This is where it's important that we get our supervisors, we get that support. I'll say, for myself, and especially in working in with high acuity populations for a number of years, there have only been, 2 occasions with all the clients I've seen, over years and years, where there was actually some homicidal ideation, which, we had to do some duty to warn, which I'll talk about here in a second. And many times what would happen is we would see that poor emotional regulation. Where client, because of, where they were in terms of their emotional development, struggled to articulate, I'm really upset with you, or I felt really disrespected when you did X, Y, and Z. So instead of them being able to articulate that, we might hear, I'm going to kill you. You better stay away from me. I'm going to get you next time you come near me. And we would hear those threats, but in reality, it was them having difficulty managing their emotions and really saying what was going on. And so that's some of that discernment and that, kind of clinical judgment that's important for us to have. And again, if I need help, that is okay. Let me check in with the supervisor. Let me check in with my colleague or a colleague. And the other piece that we have here is if a client truly is homicidal, this is where we have kind of our duty to warn. Oftentimes we hear it being just referred to as our Tarasoff duty. And that really comes from a place, especially if, we might be a clinician. And as we think about confidentiality and, when folks come to see us, all, what they're sharing and whatnot is confidential. But as we think about one of those moments, one of those exceptions to confidentiality is this here. If a client is homicidal, we need to break that confidentiality to ensure safety. And so part of that duty to warn is notifying law enforcement, as well as doing our best to notify the identifiable victim. And this again is where I would say for the most part, we don't see this very often, which is where when it happens, sometimes the anxiety and like, oh my goodness, I don't know, and whatnot can all start to rise within us. And so that's where it's really important for us to get that help and support from our client, or not our clients, from our supervisors and colleagues. Another thing for us to think about if we're looking at that kind of imminent danger is suicidal ideation. And one of the things I've seen from us as providers is I don't think anyone wants to assess suicide. It's heartbreaking to think of how many folks take their lives, how many folks contemplate suicide, but we have to. And for folks who are working with minors this applies to you. One of my, when I was doing my pre-doctoral internship, I was at a residential and inpatient unit in Indiana. And one of my first clients there was, I forget if he was 9 or 10 years old. He was a young one. And he was there because he attempted suicide 3 times within 48 hours. And just seeing him, and I could still picture him in my mind. He was so young. He was so little. Like it was just so heartbreaking to think, what is going on in your life that you tried to take your life 3 times in the past 48 hours. But we have to acknowledge folks of all ages, not just adults, struggle with thoughts of suicide. And if you are not comfortable, and not that anyone necessarily is comfortable, but if you are not confident in asking clients about suicidality and whether or not they have thoughts of wanting to harm themselves and thoughts of wanting to kill themselves, I really want to encourage you to role play. Get with a colleague, get with a supervisor, and practice asking some of those questions. So when you do need to ask a client, you feel confident asking. Because what I see, if I'm asking a client, do you have thoughts of wanting to kill yourself? And I'm kind of asking in a nervous way, like, oh my goodness, I hope my client says no. I'm not showing a lot of confidence that if you say, yes, I got you, and we got you, we're going to support you. Sometimes that client in that example is going to say no, because they can see I'm like praying to God that they say no. As we think about thoughts of wanting to kill themselves, this again is where we want to discern. Is this client suicidal, or does this client have difficulty regulating their emotions? We want to kind of discern what is going on. And as a reminder, we don't want to take just what they say when they're up here in crisis. We want to take what they say as well once they've come back down. We also want to consider here, is the ideation, is it more active or is it more passive? So for example, is the client having those thoughts of I want to die? Is the client having thoughts more of like, I am just exhausted, I just want to go to sleep and not wake up? Those are important for us to discern. Also in the chat, we have someone using the Columbia Suicide Severity Rating Scale, a great scale, and it absolutely helps, asking those important questions, discerning, what we need to do. So a great resource there for sure. And also as we even think about, kind of those thoughts of suicide, how much are they on their mind? I've had clients where they've thought about it, it is on their mind every waking moment. I've had other folks talk about it's kind of more fleeting. The thoughts kind of come and go. I've heard folks say, well, after I got in an argument with so and so, then I thought about it, but I haven't thought about it since that argument. So it varies. If a client does have thoughts of suicide, do they have a plan? And this is where it ranges. I've heard folks say, I would, whether it was, I would hang myself. I would jump off a bridge, or whatever it was. I've heard folks say they've had backup plans. Well, I would do this, and if that didn't work, I would try this, and I would do this. This is also where it's helpful, for us to think about, do we know a little bit about their history? Have they had a history of suicidality where, say, for example, they've had some suicide attempts before, and let's say every attempt has been an overdose. Well, there's a good chance that, them having some thoughts right now that attempt is going to be an overdose given what it has throughout. We also have a few things here in the chat. Plan, means, and access. Absolutely. Because I could say I'm going to do something, but I would have no idea where to get it. So that's going to be different than me knowing, when I get home, I have access to it. Also, you have to have the thought of, if you don't ask, how will you? Can you help them? Absolutely. I love kind of that mindset. If I don't ask, how am I supposed to support you? Also, is there intent? Because somebody can have a plan, somebody, can have the means, but do they have the intent to hurt themselves? I've heard folks, I've worked with folks who have attempted suicide, sometimes once, sometimes multiple times. I've worked with folks who have had suicidal ideation. It didn't go further than that. I've worked with folks who've even thought about how they might do it, but had no intent. Two of the biggest reasons I've heard that kind of play into protective factors, but two of the biggest reasons I've heard from clients as to why they would not do it is their faith and family. And like, I would not do that to my family. Those have been two of the reasons folks have had some thoughts, even had a plan, but said, there's no way I would do it. And then thinking here about, are there any protective factors? Because we also want to consider that. Because if I hear, for example, not only faith, family, friends, are they connected? Are they engaged in a community? Also thinking about, are they future oriented? Because if I hear them talking about, okay, well, I'm planning this for Christmas break, or, we're going to go here next summer and whatnot. Well, for client to be talking about next summer kind of implies that they're going to be here next summer. Are we seeing a sense of hope? Do they have things to look forward to? So as we think here about some safety plans and some things we want to consider, thinking about, we want to complete one anytime we have somebody engaging in unsafe behaviors. And again, we looked at a variety of things that could be self-injury, that could be substance use. We also have, needing to complete something like this when somebody's in an abusive relationship, whether they're in it and they want to stay in it, whether they're in it and wanting out of it, or maybe they recently left it. Because we also know in the midst of leaving and having just left can be extremely dangerous times. Suicidality and homicidality, kind of like what we were talking about. And also, and I think we really miss this one, is anytime somebody has been discharged from a psychiatric hospital. Because one would assume, well, you wouldn't be hospitalized if you weren't safe. I've met with folks after, being hospitalized, and doing a safety assessment then with them, and clients still endorsing suicidal ideation And it's just like, how did you discharge? And, sometimes they'll say, oh, I lied. I lied to the psychiatrist, told them I wasn't having the thoughts anymore, and they discharged me. I didn't like the food, and it's just like they know what some of our clients who've been in and out of hospitals, they know what to say. So we don't want to make that assumption. You're coming from a high level of care and you're good. So we want to make sure not only we're doing a safety assessment, but also that we're creating a plan for safety, because that, you being hospitalized, you literally having your rights being taken away from you, that's a huge disruption. That's a huge concern in terms of safety, crises, and whatnot. So we want to make sure we have a plan. How are we supporting you going forward? We want to make sure we are regularly reviewing and updating it as needed. Now, where this could get overwhelming is if client has lots of us on a team and every person is kind of has their own plan and updating their own plan, and we're not talking together. I've seen that when kids just throw the plans away when they leave the office because it's overwhelming. So what we need to do is we need to make sure we are talking to each other, so that way, one of us is updating, other folks are getting the updates. If when so and so meets with client, maybe there's another update there. Again, it's getting shared with us. We also want to stay focused. When we're doing safety planning, we want to focus on safety. We want to save the wellness and treatment goals for that. And we also want to think about both physical and emotional safety. Going back to earlier, how we were talking about kind of that trauma stress response, and how for some of the individuals we work with, when they get triggered, when they perceive danger, so much can get going in them. Sometimes that can lead to a crisis. So we don't just want to consider physical safety, but also that felt sense of safety. What does that look like to increase how, feeling safe in whatever environment it might be? Some questions that are also important for us to consider, is what is the plan for? We need to make sure we kind of have our focus on what is the safety plan for. Is it to protect client from harming themselves? Is it to protect them from harming someone else? Is it that they're in a dangerous situation and they're needing out? Have they left the person abusing them and they're needing to stay away from it? Is it that it's substance use? Is it that they're running away? Is it self-harm? Whatever it is, we want to hone in on what is it. And also keep in mind sometimes too, in the course of our work, sometimes we see new safety concerns emerging. So we want to make sure we're updating the safety plan as those new concerns are emerging. Some questions that can be helpful here to look at is, thinking about what are some situations where you feel unsafe. Also, sometimes it could be hard. The client might not have a good gauge for this. So that's where it can be helpful, even looking at, are there situations in which others fear for your safety? Or what are you most worried so-and-so might do if we're looking at an abusive relationship? And I love this next question because it really puts some onus on the client. What are ways you can increase your safety? Because I want to make sure I'm not doing all the work here. Because if I'm doing all the work, there is a good chance my client is not going to put into play this plan. The more they are involved, the more input they have in it, the more likely they're going to implement the plan. So we want to hear from their perspective. How can they increase their safety? And this last question is crucial. Why is your safety important? Because when we think about it, and this is where, going back, we talked about self-care earlier and how that is so intentional. Safety planning is intentional. And safety planning is an intentional engagement opportunity. Because when we think about it, if you're doing a safety plan with me, and if I don't value my life, probably not going to do what you're telling me to do. I have to value me. So I need to think as the provider, how am I conveying to them? We're putting the safety plan together because you are an important and worthy human being. And I care about you, and you deserve safety just as much as I do. They have to have some buy-in for why they're important. All right. So with that, just want to quickly go through some resources, and not an all-inclusive list of resources by any means, that are important to, be aware of. Some crisis lines, knowing some of those local emergency rooms, shelters, hotlines and whatnot. Also some resources, specific here, for you all. But with that, as we're starting to wrap up here in the next few minutes, just want to open it up if there are any questions on anything that we have covered. All right, I don't see any questions coming in, which means we're going to talk about self-care here for a moment before I hand it over to Robert. So this is where, again, we started our day and we are ending our day. Well, granted, the day is not done, but our time together. It is so important that we are intentionally taking care of ourselves. I recognize our work days are not done. There is more work, waiting for us when we get off this webinar. And I really want to encourage you, before you jump into the phone call, the email, the meeting, whatever it is, that you take a moment to do something for you. Because again, for us to help our clients navigate crises, for us to pour into our clients in the ways in which we want to, we have to be taking care of ourselves. So with that, just want to thank you all for chiming in, for joining, and for those who've chimed in through the chat. Thank you all. And with that, I will hand it over to Robert to talk through kind of all the fun closing logistics.
Thank you so much, Dr. Klasey, for that great presentation. I'm seeing in the chat several, just commendations and compliments of your training. So thank you so much for your time. We have included Dr. Klasey's contact information, the email on your slides, so that you may contact her with any further questions. Dr. Klasey, again, we really thank you for all the work you put into this webinar and all the valuable information you shared with us today. Please note a couple of business items before we conclude. I will put a link to the survey in the chat momentarily. You will be prompted to take the evaluation on FATA's website following the conclusion of this webinar. If you want to receive CE credits or a statement of credit for this event, you must complete the evaluation. At the conclusion of this webinar, your browser will take you to that evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to the CE broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you'll be directed onward to the evaluation. You must use the same email address you used when you register for our webinars and when you set up your profile in FATA's system. This is the only way to connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today. As a reminder, the evaluation closes on Saturday, September 9th at midnight. We do not email statements of credit after we verify attendance. And if you have completed the evaluation, a statement of credit will be generated as a journal entry within your profile 30 business days after the evaluation closes. Archived material will be available within 30 days. You can visit our website at www.fata.org and then navigate to the Resource Center and click on Training Library. Thank you for participating in today's webinar. We'd like to thank Dr. Klasey, and we'd also like to recognize and thank especially the Florida Department of Children and Families for funding today's education. Have a great day and please hold for the evaluation.